Hello, and thank you for joining us for this webinar on fatty liver disease in Latin America, brought to you by the Lancet Gastroenterology and Hepatology and the Lancet Regional Health Americas as part of London Global Cancer Week 2022. First, there are a number of housekeeping items before we to take care of before we get into the main presentations. Everyone is welcome to submit questions throughout the presentations using the Ask a Question box on the dashboard. The questions will be held until the end, until everyone has spoken, and we will address them in a Q&A session then. On the webinar dashboard, there is also a box of related resources, which will take you to related content from the Lancet group of journals. You can adjust and minimize any of your boxes that appear on the webinar to suit your personal preferences, and we will be sending you a version of the webinar at the end of the webinar once it is finished via email. So, fatty liver disease in Latin America. Non-alcoholic fatty liver disease, or NAFLD, is the most common chronic liver disease globally, with a prevalence of around 25 to 30%, which rises to almost 3/4 of individuals who are overweight or obese. Obesity and type 2 diabetes are major risk factors for NAFLD, excuse me, and the prevalence of obesity has increased alarmingly in Latin America since the 1990s, with some estimates suggesting that the region has one of the world's highest prevalences of NAFLD. NAFLD is a multi-system disease, which increases the risk of both liver-related complications such as cirrhosis or liver cancer, and extrahepatic conditions too, such as cardiovascular disease, chronic kidney disease, and some extrahepatic cancers. So with this in mind, we thought it would be valuable to explore fatty liver disease as a growing cause, a growing threat to public health in Latin America. Today's session will be chaired by myself and my colleague Thais Avila, who is the Editor-in-Chief of the Lancet Regional Health Americas, and we are joined by a panel of 4 experts in this area: Dr. Sylvia Sukian, Professor Mendez Sanchez, Dr. Derchwolf, and Dr. Arab. Will be taking us through 4 different talks. The first of which I'd like to now introduce Dr. Sylvia Sukian, who will be talking to us on risk factors and mechanisms of non-alcoholic fatty liver disease. Thank you, Sylvia.
To be here, and thank you for the opportunity to talk about the risk factors and mechanisms of non-alcoholic fatty liver disease. This is my disclosure. To start, I would like to introduce non-alcoholic fatty liver disease, which has emerged as a leading global cause of chronic liver damage. NAFLD is a disorder characterized by the accumulation of fat in hepatocytes. If accumulated fat causes stress and injury to the cells, then hepatic inflammation triggers a series of events that might end up in the accumulation of scar tissue, which is known as fibrosis, and these mechanisms may lead to impairs the liver function. From the clinical point of view, NAFLD can be seen as a series of disorders, starting with a non-alcoholic fatty liver that is also called steatotic liver or plain steatosis, then NASH, non-alcoholic steatohepatitis, then cirrhosis, and eventually hepatocellular carcinoma. From the histological point of view, there are other features which they have many important implications in the disease progressions, for instance, portal inflammation or even lobular inflammation, and as you can see here, the scar in the liver tissue. But the most important feature I want to remind you today is the 2 main features of the disease, which are the phenotypic complexity, meaning that not only all patients affected with the disease can progress, meaning that you have NASH and cirrhosis and hepatocellular carcinoma, but also the interindividual variability, meaning that only, for instance, 30% of the patients that have fat accumulated in the liver might progress to NASH, and only, for instance, 2 to 4% might progress to cirrhosis. These 2 features are the one I want to highlight and share with you, and see which are the factors that may lead to the phenotypic complexity and the interindividual variability. The first feature I want to share with you is the NAFLD is a complex trait. This disease occurs with one or more cardiometabolic risk factors, is influenced by the environmental exposure and lifestyle. Most important, is a polygenic complex disease and is also heritable. Let's see the importance of the association between the disease and the cardiometabolic syndrome. There is definitely a bidirectional relationship between the disease, the hepatic disease, and the components of a metabolic syndrome, and also there are shared disease mechanisms. For instance, a gene-based analysis suggests that there is a large interconnectivity network of genes that are shared by obesity, type 2 diabetes, and arterial hypertension with the liver disease. In this cartoon, you can see the main risk factors for NAFLD. There are not only the obesity and type 2 diabetes, but also other specific factors, for instance, decreased vitamin D, for instance, chronic kidney disease, for instance, the main one is insulin resistance, and as an example of the interrelationship between NAFLD and cardiovascular disease, I can show you here that NAFLD is associated with abnormal circulating levels and liver expression of molecular mediators of atherosclerosis. You can see here the hepatic immunohistochemic expression of PI1, ICANN1, and CD40, which are also the main risk factor leading to the accumulation of plaque in the main arteries. There is also an important feature, which are the extrahepatic manifestations of NAFLD. But specifically, NAFLD occurs with, as I said before, cardiovascular disease, chronic kidney disease, a variety of cancers, with OSA, of obstructive sleep apnea, and other conditions, particularly hypothyroidism, sarcopenia, osteoporosis, etc. And there is no specific knowledge about if the disease is the cause or which one is the first one, but definitely these conditions are highly associated. In this cartoon, I want to show you the intricate relationship between obesity and NAFLD, and also the importance of the phenotype known as a lean NAFLD. Because as everyone knows, that the classical phenotype of a patient with NAFLD is primarily an obese and overweight individual, exhibiting insulin resistance or type 2 diabetes and some degree of cardiovascular disease. And there is a dose-dependent relationship between NAFLD and body mass index. For instance, the risk of developing NAFLD increases by 1.2 per unit of increment of body mass index. So, lean NAFLD has become as a major clinical challenge. A comprehensive analysis we have done in the past, reviewing all studies addressing this condition, show that lean patients also suffer of NAFLD, and the association we saw is not only compare lean with obese, but also the lean NAFLD patient with those controls that don't have NAFLD, and we observe that definitely patients with lean NAFLD have risk factors, the same one that the obese patient, in particularly an increase in the fat deposition, visceral fat deposition. So, although in a lesser extent, lean NAFLD patients also share the main risk factor than the patient without obesity. In this cartoon, I want to share with you the concept, which is the NAFLD is a polygenic and heritable disease. And this was revealed by a number of seminal studies, particular familial aggregation studies or twin studies, and more recently, the Genome-Y Association study, the Exon-Y Association studies, and more recently even is the Phenome-Y Association studies. And the features from the GWAS and EWAS were replicated across the world in candidate genes studies and also in meta-analysis. And finally, there are many functional studies that bring into the light which is actually the mechanistic connection between a variant in a gene and the risk of developing NAFLD. Which is more surprising is the heritability of NAFLD is quite similar to the heritability of other complex diseases. For instance, you can see here the heritability of gastroduodenal diseases is about 30%. But in this cartoon, we try to depict the main candidates according to the novelty and according to importance. And you can see here concentrated the main loci that were associated and highly replicated with the disease. The most famous one is the PNPL3, but you have also here the other ones. I will show you now in this summary cartoon, which is the main function associated with loci, and which is really remarkable is most of the loci associated with the disease are located in metabolic genes. For instance, not only PNPL3, which is a triglyceride lipase that controls the hydrolysis of adipocytes and also the hydrolysis of the fat, but also the other loci, and which is also interesting is the localization of the protein associated with these loci, which is in most of the cases in the lipid droplets. So there are highly concentrated association network of genes and proteins with the disease are almost only metabolic genes. And in this cartoon, I summarize you the concept I want to bring into your attention, that the association between the genetic risk and the disease is based most at the moment by variants that are common variants, meaning that the frequency of the minor allele is not about 30%, and these variants have a modest effect on the disease. The one that has the higher effects is the variant in PNPL3, which is associated with a 3.3 risk of NAFLD and NASH, and explain about 5% of the variants associated with the disease. And then I want to highlight you this loci, which is HSD17V13, which is a deletion indiciation variant, which is associated with lower risk of NAFLD and NASH. And the other variants, particularly the TM6SF2, you can see here that the effect is much lower, 2.2 risk of NAFLD, and the other ones are really with a very low effect. The one in GCKR and in BOAT7 really don't show a higher effect associated with the disease. And there are many things that we don't know yet, despite our studies that are bringing more new information, is that if we have rare variants which might cause higher effects, or definitely we don't have any evidence that there is a rare allele causing Mendelian disease associated with NAFLD. But this figure is extracted from information from the UK Biobank. As you might probably know, they have a large connection of individuals very well characterized and very well phenotyped. And you can see here that the variant in PNPL3 is not only associated with the risk of NAFLD, but also with the risk of fibrosis associated with other liver diseases, including alcoholic liver disease. But surprisingly, there is a protection effect with cholelithiasis and also with diseases of the biliary tract, which is really don't know the cause. In this figure, I want to bring into attention, which is the global prevalence in NAFLD risk variants in the 1000 Genome Project, which might probably show you the disparate geographic patterns in the risk and protected alleles which might probably drive some of the disparity between the geography and NAFLD incidence. For instance, you can see here the prevalence of the variant in PNPL3, which confer risk of the disease in Peruvian individuals in the 1,000 genomes is about 70%, which is really, really high. But at the same time, this population in Latin America has the lower minor allele frequency in the protected allele of the gene, which is the main one associated with the lower risk of the disease. But as I mentioned before, the genetic risk factors are only one part of the explanation of the pathogenesis of the disease. And the all things that are not explained by the genetics are also usually named under the heading of missing heritability, which comprise the environmental exposure and the epigenetics and the interconnection between many other factors, for instance, the microbiome, the acetylome, the methylome, and the interaction between the genes. So what do we need to understand the biological mechanisms of the initiation and the progression of the disease? My summary word is knowledge. We do need to know about the perturbation of physiological processes in a multi-scale biological information-driven studies, particularly from the DNA, RNA, protein, metabolites, and the metagenomes. And also we need to understand how the system works. This is, in a one word, interaction. So when we have all this information, we might integrate this information with the clinical information, and then we can efficiently translate this knowledge into decision-making for healthcare. So as I mentioned before, there are many metabolic factors, which are summary in this cartoon. You can see most of them are metabolic ones. But I can tell you that there is a stepwise progression of factors which interact with pathway associated with type 2 diabetes and obesity. And these factors are leading eventually to hepatocellular carcinoma in a stepwise fashion. So I mentioned before there are many other mechanisms, for instance, epigenetic mechanisms. And that's why almost 10 years ago, we started to study the epigenome in patients with NAFLD, particularly in the liver tissue. And we target one specific transcription factor, which is the coactivator of PPR gamma. And because this is a master gene that controls metabolism and also mitochondrial biogenesis. And we observed that the gene is associated with promoted hypermethylation in the liver, and also this condition was associated with lower mitochondrial copy number and also with higher insulin resistance. This is consistent with the fact that other investigators observed in the liver tissue and in an analysis of the alteration in methylation patterns before and after bariatric surgery, that also this target transcription factor might be partially reversible in the epigenetic modifications. We then study a different molecular approach, which is the study of the DNA methylation of mitochondrial DNA. And we specifically study the mitochondrial NDX6 because it's a main complex of a respiratory change. And we observe that in the disease severity in NASH, this gene was hypermethylated, and this state of hypermethylation was associated with downregulation of gene expression in NASH and fibrosis, downregulation of protein expression, and many defects in mitochondrial morphology. Regarding the molecular mechanisms, we also observe that in the liver of patients with NASH, there is a significant downregulation of a master mitochondrial microRNA 122, which is the main microRNA expressed in the liver. But this downregulation in the liver expression of this particular microRNA was associated with the upregulation in the serum. And this caused defects in the translation and activation of the main enzyme from the liver, which is LAT. To enter the concept of the multifactorial factors associated with the disease, I can show you here from the liver progression, from the healthy liver to fatty liver to NASH and eventually hepatocellular carcinoma, the series of events associated with the interference with microbial signals and microbial metabolites, which can alter the immune response, the inflammatory response, and also can trigger fibrogenesis. And regarding this, I will end our features about the intrahepatic microbiome in NAFLD, which was specifically profiled very recently, in which we observed that the liver tissue has a diverse community of bacterial DNA, and for this particular situation, we observe that the obesity is an important driver of a microbial DNA composition. For instance, which is important of this? For instance, we have some bacteria, particularly proteobacteria, that were increased in NASH, and some other family of bacteria that were significantly decreased in NASH. And so this association between the severe histological features and the some bacteria led us to the hypothesis that they may trigger the disease progression. And here in the bottom of the picture, you can see the immunohistochemical expression of a bacterial LPS, which is particularly high around the portal tract, and particularly in patients with NASH fibrosis. And finally, we try to interconnect all the things I talked before in this talk, including the variants that confer risk and protection against the histological severity, and also a variant that in a way determine the micronutrient intake and also the tissue microbiota, and we try to bring a novel perspective in the understanding of the disease biology, because we found that there were 18 bacterial taxa associated with the tissue microbiota, and also we found that approximately 7.4% of the genus associated with the microbiome were explained by the polygenic risk score. So I think I don't have much time to show you this, but briefly, there are many variants associated with each of the loci I mentioned before, and there are also a polygenic risk score that could eventually link the association between NAFLD and also cardiovascular risk. So I thank you for your attention, and I hope you enjoy the conference and the talk, and I will be happy to take questions at the end of the webinar. Thank you.
Apologies there for the slight technical glitch. I would now like to introduce Professor Mendez-Sanchez, who will be talking to us on the epidemiology, detection and management of non-alcoholic or metabolic associated fatty liver disease from a Latin American perspective. Professor Mendez-Sanchez, over to you. Thank you.
Thank you very much for the introduction. First of all, I would like to thank the scientific committee to invite me for this great event. My disclosure, and in the next 20 minutes, I will talk about the definition, epidemiology, detection, and management of the fatty liver. As you know, since 2 years ago, an international committee of experts suggests the new definition of metabolic dysfunction associated fatty liver. Using a new definition is on the way, but we will see in the future if we fix with a fatty liver, with the complete definition of fatty liver. This definition includes or detect the by imaging techniques, blood biomarker scores of liver biopsy, the hepatic steatosis in adults. Those patients, they have to have at least obese, they have to be obese or overweight. And if they are also type 2 diabetes, they meet the criteria. However, if they are lean or with normal weight, at least they have to have 2 metabolic risk abnormalities, like waist circumference, blood pressure, plasma, triglycerides higher, and also another condition. This study, the Rotterdam study, support the new definition, because let me tell you that in this study that started in the 90s, the investigators analyzed across from the 2009 and 2014 more than 5,000 patients, and they divide those patients in NAFLD analysis and NAFLD. Later, they divide also in subgroups with non-NAFLD and NAFLD, and also non-NAFLD and NAFLD. They were looking for the fibrosis identification by using the liver stiffness measurement higher than 8 kilopascals, and they compare these 3 groups. And you can see the NAFLD alone is able to identify more accurately the fibrosis, the liver fibrosis, compared with the other groups. On the other hand, let me tell you about the mortality causes in America. As you can see in this slide, the liver cirrhosis and other chronic liver disease constitute the 3rd cause of mortality in our region. Also, NAFLD is the common cause of chronic liver disease and cirrhosis in different groups of in the world: Latino, Japanese American, Native Hawaiians, African Americans, and white, respectively. Now, what about the epidemiology of NAFLD in Latin America? We have a few information in our region. However, this study, this systematic review and meta-analysis speak about the prevalence of NAFLD in our region. This is a study from a colleague from Peru and Chile, and they identified more than 13 studies, and finally they analyzed 19 studies which meet the criteria. And they found that the prevalence, when the studies used the ultrasound, 46%, with liver biopsy 80%, and with magnetic resonance almost 70%. The overall prevalence was 59, respectively. Those 19 studies came from Brazil 11 and from Mexico 6 and other countries. And look, this study was included the highest number of patients, more than 2,500 patients, and especially they include men. When the investigators analyzed the prevalence by group of risk population, you can see in the case of the diabetes, the prevalence range from 56 to 64. But this prevalence increased in the case of obese patients because it's higher, at least until 90%. The overall prevalence was 68% in this study. Now, in some studies, investigators use the liver biopsy, and they look for the proportion of NAFLD, hepatic steatosis proportion, steatohepatitis, and liver fibrosis. Were 9 studies, and 5 were from Brazil. And the proportion you can see in this case is very high, the prevalence, especially in fibrosis, liver fibrosis. So, in conclusion of the prevalence of NAFLD in our region, in Latin America, we need more information. But you can see in this systematic review that we have a very high prevalence at this time. How we can detect the NAFLD or fatty liver? Probably the ultrasound, hepatic abdominal ultrasound is the most useful tool to identify this condition. But now we have another tool, very good tool, that is the elastography, the magnetic resonance in some places, but probably the non-invasive biomarkers are the more common useful tools to identify this condition. The liver biopsy is useful, especially in clinical trials, because it can identify NASH and also some alteration like hepatocyte ballooning and lobular inflammation. However, non-invasive scores, we can use the biomarkers, fibrosis scores, and elastography to identify some patients with advanced fibrosis. When we combine, the accuracy increase and also reduce the need for the liver biopsy. The non-invasive also we can use for monitoring the liver fibrosis progression and the liver cirrhosis. And in some cases, we can use the liver biopsy. It can be suggested every 5 years in the follow-up for evaluate the outcomes. The non-invasive biomarkers, probably the most common ones are the FIT4 and FNFS and ADAPT algorithm. You can see the negative predicted value in the case of the NAFLD score is from 80 to 90%, and in the case of FIT4, the predicted negative value is around 55%. So, in conclusion about the tools that we can use, we have now some tools that is easy to use and identify very well our patients. Now, this is my last part of my talk, and I will talk about the treatment. The main aim of this the treatment is the prevention and regression of liver damage. We can to keep our liver healthy, we need to use healthy liver, we need to have a healthy lifestyle, but in the case of fatty liver, we need to lose weight and to do physical exercise. So the components of lifestyle approach for fatty liver, you can see probably the most important are the energy restriction and physical activity. But don't forget that the fructose intake and the daily alcohol intake, we need to avoid them. And also the coffee consumption, because you know the coffee consumption, it has been associated with the decreased progression of liver fibrosis. At this time, we don't have approved any pharmacological treatment for NAFLD and MAFLD. So why is the lifestyle intervention very important for our patients? Let me share with you this study from China. The investigators did this study in 33 clinics, and they include 577 adults with impairment glucose tolerance, and they use diet and physical exercise, and the intervention was for 6 years. 94% of patients completed data sets, And finally, the investigators evaluate 407 in the group of intervention and 135 patients with the group of control group. You can see in this slide that the intervention, the lifestyle intervention, decreased the mortality in all of the cases. And also in this graph, we can see how we can decrease also the mortality related with cardiovascular disease and also the incidence of diabetes. So how much we have to weight loss to nice resolution and to the fibrosis improvement? Dr. Gomez Vilar and his colleagues, they did this very interesting study in 7 years ago, and they published this very good article. They used hypocaloric diet, aerobic exercise, and they treat the patient for 1 year. And they look that the 10% of lose weight is enough to nice resolution in 90% of patients, and the fibrosis improvement in 81% respectively. How about the exercise without weight loss? This is a very interesting study from Johnson and colleagues. They treat 19 of these patients for 4 weeks, and they found no change in the body weight and also the subcutaneous adipose tissue. But when they measure the visceral adipose tissue and the fat, the liver fat content, they could see a decrease in these two variables in 21% compared with the placebo group. So the effect of moderate on vigorous exercise on the intrahepatic triglyceride content is very important. And in this study, compare how it looks when we use moderate and vigorous exercise. And finally, the investigators found that this the same effect. So we can use moderate exercise for our patients. So, you know, the lifestyle modification, it has a very important effect. And the aerobic exercise, you know, there is an activation of lipolysis, the upregulation of UCP1 protein, and also the PPI gamma receptors, and also the alteration of the adipokines. The resistance exercise also, there is a very good change in the alteration. And in conclusion, we can say that the improvement in this patient is about 50% of the cases when they without weight loss. Now, what happened in the group of patients with morbid obesity? As you know, those patients have 90%, around 90% have fatty liver, 37% NASH, and almost 2% liver fibrosis. So the bariatric surgery reduced the feature of NAFLD in morbid obese patients because it can decrease the fatty liver content after 1 year, and also the NAFLD activity score after 1 year. Some parameters of inflammation also improve after 1 year, like hepatocellular ballooning and lobular inflammation. In the case of liver fibrosis, also there is an increase and decrease in about 33% of the patients. Now, what about the clinical practice guidelines? They suggest the different international societies, they suggest that to use the glycosomes and vitamin E, and in the case of the European Association for the Study of the Liver, they suggest associated with ursodeoxycholic acid in high dose. But the other societies also are in favor to use vitamin E and pioglitazone respectively. You know, in this slide, you can see how the different therapies can improve the liver steatosis, like vitamin E, pioglitazone, largitude, obeticholic acid, and others. The dose of vitamin E has been suggested to use 800 units per day, and the pioglitazone 30 milligrams per day. What about the NAD resolution? You can see that the percentage that in the efficacy of these drugs, and also the bariatric surgery in compared with the placebo group. There are many studies about vitamin E, but probably the most important one is from the Dr. Sanyal and colleagues, and they did in 247 patients with NASH. They treat for 96 weeks, and they found a very good reduction in the NASH in 43, and compared with the placebo in 19%, no in 20, 19% respectively. So in the you can see in this slide, in the case of the aminotransferase, they can decrease compared with the placebo group, and also the insulin resistance decrease in the pioglitazone, but in the weight, when they analyze the weight, there is a gain in the group of pioglitazone. And finally, we can say that the vitamin E, it has a very important effect to decrease the oxidative stress. That is one of the main line in the pathophysiology of fatty liver. To summarize this lecture, I will conclude to say that the chronic liver disease constitutes the lead cause of overall mortality in Latin America. NAFLD is the recent nomenclature to fatty liver disease due to its more accurate disease characterization compared to the previous one, NAFLD. The diagnosis of fatty liver can be done through imaging techniques and non-invasive biomarkers. However, liver biopsy remains the gold standard in some cases, especially in research. Risk of fibrosis in NAFLD patients depends on risk factors and can be useful to calculate by using scores such as FIT4, NFS, and the ADAPT algorithm. The first line of treatment includes lifestyle modification, including 10% of weight loss. And finally, there are currently no pharmacological treatments for NAFLD, but vitamin E and pioglitazone have proven effect to reduce the severity of liver damage in our patients. Thank you very much for your attention.
Thank you very much, Professor Mendez-Sanchez, for that fascinating talk. We will now move on to the next talk from Dr. Melissa Derschwolf, who will be discussing NAFLD and cancer risk. Over to you, Dr. Derschwolf. Thank you.
Thank you very much for this kind invitation. I'm very happy to be here. So, as you well know, the current burden of liver cancer worldwide is quite significant, since liver cancer is the fourth most frequently diagnosed cancer and is the second leading cause of cancer-related death. When we look at the incidence by region, you can see that Latin America has the lowest age standardized rates, whereas the Caribbean has higher numbers, close to Northern America. When we account for hepatocellular carcinoma, it represents by far the majority of liver cancers. But the incidence of liver cancer has been increasing significantly in the last years. And as you can see, in the last 25 years, it increased 75%. And this has been attributed to the combination of the aging of the population, but also to several diseases like hepatitis C, alcohol use, among other causes. Now, this is changing in the present. The etiology for the hepatocellular carcinoma is changing. And as you can see here in this waiting list analysis in the US, you can see that even though hepatitis C was the leading etiology and it increased during this period from 2002 to 2012, NASH-related HCC was the second leading etiology, and it increased fourfold during this decade. And a very similar phenomenon happens in Latin America. In this study, you can see that viral hepatitis have decreasing trends, whereas NAFLD-related HCC presented a six-fold increase in liver transplantation patients in the same study period. And we can probably wait for these trends to continue their direction. This is a Markov model analysis that it shows what is the burden for NAFLD that can be expected up to the year 2030. And you can see that in Japan, the incidence of HCC related to NAFLD is expected to increase 44%. But in countries such as France and the US, this proportion is expected to increase over 122%. So this trend is expected to keep its direction. But why are we seeing these numbers? Why are we seeing these trends? And it's interesting because when you look at the incidence of HCC according to the underlying liver disease, well, we all know that hepatitis C has a higher annual incidence. You can see here in this very interesting study that the annual incidence was 4%. It's almost twice as much as you can expect for NAFLD or NASH patients. But what we have to bear in mind is that the strength of association is not all that matters. If you consider population attributable fraction, which is an estimate that takes into account not only the strength of the association between the risk factor and the outcome, but also the prevalence of the risk factor in the population. And this is a way to really assess the impact that a disease has in HCC incidence. Well, you can see in this interesting analysis in the Medicare large database that even though hepatitis C had the highest odds ratio, it had a lower population attributable factor when you compare it to patients with diabetes and or obesity as surrogates for NAFLD. So if you can see here, it's quite higher. And the authors mentioned that eliminating diabetes or obesity could reduce the incidence of HCC more than eliminating any other factor. So if you consider that this paper was done before the wide access to direct-acting antivirals, maybe if we look at these numbers now, they would be even more impressive. So what about modifiable and non-modifiable risk factors for HCC in NAFLD? We can start with non-modifiable risk factors. And as you can see here, this is a large retrospective cohort study that analyzed patients with NAFLD cirrhosis. And you can see that those with higher risk were patients that were older than 65 years old, that were male, that were from Hispanic descendants or living with diabetes. And also, as Dr. Sokoyan beautifully showed us, there is a genetic association that has been established with NAFLD HCC. And one of the most well-known genetic predispositions is from the pathogenic PNPLA3 SNP. And in this meta-analysis, you can see that it was associated with increased risk of HCC in patients with cirrhosis, particularly in a subgroup analysis with patients with alcohol-related or NASH cirrhosis, not with other etiologies, suggesting that it might have a particular role in this underlying liver diseases. So what about other modifiable risk factors, other comorbidities? So histological severity is by far the best known comorbidity that is associated to the risk of HCC in NAFLD patients. This is a very nice study that showed us over 8,000 Swedish patients with histologically defined NAFLD that were followed for a mean period of 14 years. And as you can see in the graph, HCC incidence rates increase monotonically across categories. At the bottom, you have simple steatosis, and then you have NASH without fibrosis, non-cirrhotic fibrosis, and then cirrhosis. So the highest HCC incidence rates were found, of course, in patients with cirrhosis, but also in patients with non-cirrhotic fibrosis and diabetes, showing that there is a worsening according to the histological severity. And it also shows something that we already know, is that NASH is a leading cause of hepatocellular carcinoma in the absence of cirrhosis. So this is another meta-analysis that shows in patients without cirrhosis, it compares patients with NASH or other etiologies. And as you can see here, NASH patients without cirrhosis had a nearly threefold increase of HCC risk when compared to other etiologies. But what is hard to assess is what's the real incidence for these patients, for NASH patients without cirrhosis. So we do know that the incidence for patients with cirrhosis and NASH, it's about 10 to 15 per 1,000 patients here. And we also have good numbers for fatty liver disease, but for NASH patients, there are not robust estimates because available data comes from highly selected NASH patients that were biopsied and were followed very strictly. And this paper shows that very consistently. So in this study by Rach, you can see that available studies that talk about the incidence of HCC in patients without cirrhosis and NAFLD differ in patient characteristics, in comorbidities, in alcohol use, in NAFLD diagnostic strategies. You can see in the graph, the screening is very varied, the tools, the intervals. So this all precludes from accurate estimation of HCC incidence in this population. Obesity is another well-known risk factor that was independently associated or predictive of HCC. But as you can see here in this UNOS database analysis, it was only associated with cryptogenic cirrhosis and alcoholic cirrhosis. And cryptogenic cirrhosis was thought to be integrated mostly for NAFLD patients. So obesity has an independent role, even adjusting for age, sex, diabetes, and race. And I've mentioned diabetes several times, and this is because the association has been very clearly shown. So this is another study that shows it very clearly. I think in this retrospective cohort study, diabetes was associated with a fourfold higher risk of developing hepatocellular carcinoma in NASH patients, even when adjusting for other risk factors. So it just shows the strength of the association. And perhaps this is also very compelling because all metabolic syndrome components have been described as risk factors. And here you can see the stepwise increase in the risk of HCC when you add each metabolic trait, diabetes, hypertension, dyslipidemia, in patients with cirrhosis and in patients with NAFLD and without cirrhosis. So what about lifestyle interventions? So alcohol is also a very well recognized risk factor. And in this very interesting study, you can see that in patients with NASH cirrhosis, patients who reported any lifetime alcohol consumption were 3.6 times more likely to develop HCC than those who had no exposure to alcohol. Coffee has an inverse relation, so it's a protective factor. In this meta-analysis, you can see that increasing coffee consumption by 2 cups per day was associated with a 35% reduction in the risk of HCC. And this association was maintained after adjusting for the underlying liver disease and other comorbidities. And physical activity has also been associated, or it's also identified as a protective factor, and it has even total physical activity or vigorous physical activity was associated with almost 50% risk reduction for HCC. Although it has to be said that waist circumference and BMI explained a lot of its association. So maybe it exerts its action through weight loss. And finally, when we look at chemo prevention or medication, several medications, I'm just showing a few of them because of time restrictions, but statins, aspirin, and metformin, maybe are the ones that we have all read about. So all of these drugs have been associated with a 30 up to 50% reduction in HCC incidence. But it has to be said that this data comes from observational studies. There is high heterogeneity, and we really do need control trials to establish causality. Okay, and what about extrahepatic cancer risk? This is one of the available meta-analyses, and as you can see here, NAFLD was significantly associated with 1.5 to 2-fold increased risk of GI cancer, and a little lower numbers, 1.2 to 1.5-fold increase in lung cancer, kidney, breast, or gynecological cancer. So all of these hazard ratios were independent of age, sex, smoking, obesity, and diabetes. But it has to be said that they come from studies that they didn't have physiologically defined NAFLD patients. So we probably need further data. So who should we screen? Which patients with NAFLD should be screened for HCC? As you can see, there is consensus among scientific societies about screening patients with cirrhosis. But there's not consensus when we talk about patients with NAFLD without cirrhosis. Some societies do not recommend it, and some societies recommend for F3 fibrosis patients, maybe according to their individual risk or when they have concordance of a non-invasive method. So this is a little bit more heterogeneous. So what are the pitfalls when you base surveillance in NAFLD patients only on fibrosis? So it really ignores other risk factors, and I've shown that they are quite significant associated with the risk of HCC. Even in patients with cirrhosis, it doesn't discriminate between different kinds of risk among patients with cirrhosis. If you only surveil patients with F3, you would still not detect patients with NAFLD-related HCC in F1 and F2 stages of fibrosis. Or maybe if you surveil all patients with F3, this wouldn't be cost-effective. It would fall beneath the cost-effective threshold. So some authors, some researchers, they endorse the individualized approach to HCC screening, or the precision screening for patients with NAFLD, where we not only consider fibrosis stage, but also demographic factors, comorbidity, environmental factors, medications, genetic polymorphisms, and all of this information should be integrated into our risk calculator. And in that way, we could assess risk estimation for an individual patient, and we could decide whether our patient deserves surveillance, what would be the optimal tool, the optimal interval. So we're not there yet. There are a few publications in this direction, but we're not there yet, and that they have to be validated and further studied. When we consider the strategy or the tools that we have for screening for HCC in NAFLD patients, so most societies endorse US-based screening, but as you can see in this paper, almost 20% of patients when they were studied with ultrasound had inadequate studies for excluding HCC, and the variables that were associated with this inadequacy were child C, obesity, and NASH cirrhosis. So our patient population might be the ones that are less favored. And this is one of the strategies that has been suggested. Bear in mind, there are several others. But abbreviated non-enhanced MRI has been proposed as a tool for high-risk patients, and it showed to have better sensitivity, specificity, positive and negative predictive values. But this has not been validated in NAFLD patients, and it should be done in the future. And of course, this is all very interesting. We have to define which patient should be screened and what is the best tool and the best interval. But what we're facing now is that the major pitfall that HCC surveillance has is its underuse. In this recently published systematic review, you can see that only 1/3 of HCC are detected under surveillance throughout the world, and in Latin America, less than half our patients have an HCC diagnosis under surveillance. So, of course, we have to improve our surveillance strategies and decisions, but we also have to use surveillance for it to be effective. Thank you so much for your attention.
Thank you so much, Melissa. And thank you for your beautiful presentation. We are moving on to our next speaker, who is Juan Pablo Abad, and he will talk to us about NAFLD and public health policy in Latin America. I'm really excited for this one. So thank you, Juan, and please, the floor is yours.
Well, thank you very much for the invitation, and thanks all the attendees for being with us today. So we already discussed this. So when we are talking about NAFLD, we have a population of patients with normal liver. Then some of them will develop isolated steatosis. A percentage will progress to more advanced form of the disease with steatohepatitis, which is basically the inflammatory form of the disease, with different degrees of fibrosis, and all the way down to cirrhosis and all the complications, including the hepatocellular carcinoma. Why is this important? Because we are talking about a significant proportion of the population that will have the different degrees of this disease spectrum called fatty liver disease. So going to the numbers, how much of these patients will have NAFLD? There are different approximations to this in this paper from 2016. It was estimated that about 25% of the global population will have NAFLD. And as you can see in the graph, the higher prevalence was indeed in South America, 30%, and in the Middle East, almost 32%. So we are talking that in Latin America, the prevalence of NAFLD is very high, probably one of the highest in the world. In this particularly systematic review and meta-analysis from this year, we analyzed the prevalence of NAFLD first in the general populations, and the numbers were around 24% of the general population. Obviously, it's very different which type of diagnostic method you use for the diagnosis. If you use abdominal ultrasound, which is the most common, will be anyway from 14% to 83%. And if you go for liver biopsy, well, will be from 62% to 92%. But obviously that is a selected population, so you have a selection bias when you are only selecting patients that were diagnosed with biopsy, because you did the biopsy for any reason in that patient, for elevated liver biochemistries, or because you had any finding or any concern that that patient is already progressing. So depending on the diagnostic method, also you will have a different estimation, but around 25% of the population in Latin America, general population, it will have NAFLD. If you go to high-risk groups, and basically here we consider patients with type 2 diabetes mellitus or obesity, this prevalence can be as high as almost 70%, so 68% of the population in the high-risk groups. And why this is important is because NAFLD is a very significant proportion of patients with cirrhosis. So with this data from 2019, you can see how some of the countries had very high mortality due to cirrhosis. This is data from 2019. You can see here, especially Mexico, Chile, and Bolivia, and on the graph on your left. And then on the graph of your right, you can see how this correlate also with the incidence of hepatocellular carcinoma the same year. So we know that obviously cirrhosis is a risk factor for having liver cancer, in particular hepatocellular carcinoma. So if the numbers are increasing for NAFLD, also will be for liver cancer. And this is true because we have very high numbers, like almost a quarter of our population, and all the modeling of NAFLD are expecting that this number are only going to increase, in the total case of NAFLD, or patient with NASH, the inflammatory form, or cirrhosis, or different degrees of fibrosis, or including hepatocellular carcinoma and the need of liver transplantation. So this is an epidemic that is already ongoing and is not improving. So we need to think about what we can do to stop this to continue increasing. And if you look like from 1990 to 2019, how is the prevalence of non-alcoholic fatty liver disease in Latin America? You can see a clearly trend to increase on these numbers. So we know that we have higher prevalence of NAFLD, and we know that these numbers are increasing. And also why in our Latin American population, and we know that NAFLD is a very heterogeneous disease, and you will have different phenotypes depending on age or sex or genetics. Already Dr. Sokoyan told us about PNPL3 and other genetic predisposants that are affecting our population. Also microbiome or metabolic health, the type of diet, the alcohol consumption, and physical activity. So these are things that are particular for our population in Latin America, and we need to consider when we are thinking about, number one, the prevalence, and number two, how we are going to intervene. So we need a call to action for Latin America. So we know that we have a high prevalence of obesity and diabetes, but we need to integrate the screening of NAFLD into health checkups, for example. If we are waiting that every patient will be seen by a hepatologist, that's probably not realistic. These patients are being seen in primary care by general family doctor, general practitioners, internal medicine, or endocrinology. We need to improve awareness. The other problem that we have in Latin America is that we have a fragmentation in our health system. And this is a barrier that we need to acknowledge, and we need to think how we can work in multidisciplinary care to improve the access and overcome fragmentation. And the other thing is task shifting. As I was telling you, I mean, it's impossible to think that every patient with NAFLD, which is 25-30% of the population, will be seen by a transplant hepatologist. This is not realistic, and this is not possible. So we need to share the workload and share it with other healthcare professionals. We need to include dietitians as a very relevant part of the team. We need to include nurses and other healthcare professionals to take care of these patients. So when we are discussing this with different societies and different group of experts in how we can develop a public health agenda to address NAFLD. So the first question is what? So we need to basically develop a guidance on how we are going to screen and test this patient, ideally in a non-invasive way. We need to develop pathways on how we are going to refer this patient to the specialist. Then who is going to do it? So we need to have multidisciplinary teams that are taking care of these patients. Where is this going to happen? So we need to articulate roles. We need to improve the communication between primary care, secondary care, and tertiary care to give the best options to these patients. And then how we are going to do it. So we need to establish like a system and pathways. We need to integrate care across the whole health system. So when we were analyzing the data that is available regarding to NAFLD in Latin America, and this is a study published by Dr. Luis Antonio Diaz in Lancet Gastroenterology and Hepatology this year, we look at what was happening in Latin America. We took, this is for whole America indeed, we took 17 countries, more than 900 million people with the population in 2019, basically accounting for 93% of the continent population. The life expectancy in the continent is 76 years, 34.7% of the population is overweight, 23% has obesity, 8.5% has diabetes, and almost 20% has hypertension. So when you look at the median prevalence of NAFLD-related chronic liver disease, basically talking about cirrhosis, is almost 14% in the country. These numbers are huge if you consider that the population in the continent is almost more than 900 million people. And the median mortality due to NAFLD chronic liver disease is 2.5 per 100,000 people. So we are talking about very significant numbers of liver disease. And it's also the incidence. So as we were discussing, this is increasing. The incidence of hepatocellular carcinoma is 0.3 cases per 100,000 people. And then also these usually affect people in their most productive year of life. So the DALYs due to NAFLD are almost 80 DALYs per 100,000 people. So the burden of disease is very significant. Then what are we doing regarding public health policies to reduce the NAFLD-related burden? If you analyze what the countries are doing regarding not even NAFLD direct policies, but like NAFLD-related conditions such as diabetes, obesity, dyslipidemia, cardiovascular disease, hypertension, or specifically cirrhosis, hepatocellular carcinoma, or an alcohol use disorder, you can see how it's very heterogeneous, how the countries are approaching these non-communicable diseases. Brazil is probably the one which is doing best on achieving every disease, and then Haiti is probably the one that doesn't have any policies. Other important topic is who is taking care of these patients with NAFLD. So I was surprised that not in every country primary care providers are taking care of this patient, and they should be. That we can't wait that hepatologists are going to take care of these patients. Probably internal medicine, endocrinologists, and diabetologists should do it. But I think the most important workforce will be our family physician, a general practitioner, and the people in the primary care setting. Basically, when we were analyzing how countries are doing regarding different national policies or national registers for NAFLD, only 29% of these 17 countries has a national campaign to raise awareness about NAFLD. 41% has a register of the disease burden. So to know how many people is affected. Only 18% of the countries has a register of incidence and prevalence of NAFLD. 24% included NAFLD among the national disease registers, and none of the countries has a detailed national registry of mortality from NAFLD, which is surprising. I mean, we are not even clear about the disease burden and how we are investing from our healthcare resources and how it's affecting our population. And if we take like a parallel what happened with alcohol-related cirrhosis, which is also the other big liver disease in this study from Dr. Diaz too, basically we saw that the alcohol attributable liver cirrhosis death in 2016 is different in different countries in Latin America. And this correlates with how many public policies are established to reduce the alcohol-related burden. So doing a parallel, this also could be applied for NAFLD. And what we saw was that in the country that has more public health policies to reduce alcohol consumption also has reduced alcohol-related liver disease mortality. And this is same with alcohol use disorder. So if you have more public health policies aiming to reduce alcohol consumption, you have less of the outcomes of the consequence of alcohol use. So we should think that this can be applicable for NAFLD. Obviously, not every single public health policy has the same weight or the same effect. So we need to tailor these, number one, specifically for NAFLD, and number two, specifically for each of our population. We know that we take Latin America as a whole, but there is intrinsic difference between countries, and it's a very heterogeneous region. So what we should do with NAFLD, how we can move ahead, or which is the public health agenda. Number one, we need leadership. We need to make global coalitions. We need to define how we are going to move forward. We need to have resources. So we need to think about which is the economic burden and how we are going to put some resources there that at the end will be cost effective. We need to increase awareness. I mean, it's still very surprising that many doctors and many specialists in the field are not aware of the consequences of NAFLD. We need better treatments, better care. And then we need to have policy strategies as a whole society approach. I mean, we are, most of us are liver doctors and we care about the liver, but then we need to incorporate NAFLD in other non-communicable diseases. For example, diabetes, cardiovascular care, hypertension. We need to talk about the same language that primary care doctors are talking. So we need to make it simple, and we need to incorporate these as a whole, like health, cardiovascular or liver health or metabolic health. We need to incorporate patients and community. Their vision is very important on how we are going to address, because basically this is lifestyle intervention, and it's very difficult to incorporate lifestyle changes if we don't consider the patient and community view. And finally, we need to define better models of care, how we design which patients needs to be referred and how. So in summary, the prevalence of NAFLD and its related complication in Latin America is not only high, but is increasing. In Latin America, face particular challenge. We have a high disease burden, and we have a very fragmented healthcare system. We need detailed registers on the burden of NAFLD, and we need efforts to raise awareness. The implementation of public health policies are urgently needed in Latin America, and this may reduce the disease burden. And we need to collaborate with other scientific societies, with policymakers, to tackle this disease together. Thank you very much.
Thank you so much, Juan Pablo. This was really great. And thank you, everyone, every speaker. I'm going to start to tackle some of the questions that we have in our inbox. So the first question is for Dr. Naum. And Luis Garrido asked, what is your best advice on diet recommendation for NAFLD patients? Do you recommend Mediterranean diet, or just a reduction in calorie consumption will be enough?
Well, thank you very much for the question. There are different societies that suggest that the energy intake in terms of calories between 1,000 to 100 or 200 is enough for our patients. So the kind of diet that we can use is mostly decreasing in energy, but very recently also it has been suggested that vegetarian diet or the other kind of diet it's sometimes it's very, very tough for our patients to follow for a long period, and the adherence to the diet is very hard for them. So at least we can use the diet for some periods between 3 to 6 months, but no more than that. You know, in this study from Dr. Gomez Villa that I mentioned before in my talk, they use for 1 year, but you know, they have a lose patient because they couldn't complete that period. So, but in conclusion, I can say that probably the most important is to decrease the energy in our diet.
Okay, that makes sense. Our next question is, so from, maybe that's for Juan Carlos, maybe best. So from public health and disease prevention perspective, are there any quick win policies that we can put in place rapidly and affordably? Are there any regional examples that we could follow? So any other countries that did something that we could follow as an example? That's
that's a great question, and I think that's a key point. Basically, when we are talking about policies, so we have two big groups. Number one is education awareness, and number two is taxation. I think from the educational side, we have the example of what was done in Chile almost a decade ago, where it was implemented an obligatory labeling on food. So basically, for if you have even ever been in Chile, every unhealthy food has a tag which shows if it's high in calories, high in sugar, high in salt, and those is by law. I mean, needs to be labeled as high in calories, because most of our population does not have enough education to understand when you are putting on calories or even on grams of carbohydrates. So we need easy and simple labeling on foods to people recognize when they are high in calories or sugar and avoid those. That's, for example, an easy way to do it. And the other part is taxation. And these probably, the further examples comes from the alcohol war, where, for example, the implementation of minimum unit pricing in the UK or other countries that have done the same, is basically when you increment prices on unhealthy things that can be alcohol or unhealthy food, people will avoid those. But at the same time, we need to make public efforts to make healthy food more affordable, because we live in a paradox where the cheaper food is the most unhealthy food and should be the other way. But I think those are kind of the main challenge to make a society change regarding NAFLD.
Well, thank you. Yes, that's a key point, right? How do we make something healthier, cheaper, and encourage at the same time people to change their consumptions? Okay, what's our next question? So we have a really big question here. So I have actually, that was my question that I had for Sylvia earlier, thinking, how close do you think our knowledge is in the mechanisms underpinning NAFLD to translate that to apply biomarkers to find risk factors to use it in clinics as a biomarker for risk factor?
Okay, thank you. This is a fantastic question, because I want to be positive at this time, and I would say that the progress is paramount, because If you think when we started with this disease, nobody knows anything about the mechanisms, and the only thing we knew at the time, at the beginning, was that it's non-alcoholic related. And now we have many pathways in different stages of the diseases. The real challenge is to make all this knowledge translatable, is to figure out how the different pathways we know today interact each other, and how each pathway can be addressed in a simple way to put into the clinic. So my explanation is we are in the middle of a path to getting the ideal biomarker. Probably we solve this issue for the first stage, called NAFLD or simple steatosis, but the real challenge is to have a good biomarker which can be generalizable across the whole populations, which can be cheap and easy to implement in the clinical setting. Because when we talk about, for instance, microRNAs or proteomics or other omics, this is really nice knowledge. This is good for science, but as a physician, it's not really practical. So I think we have a lot of knowledge, and the compromise right now is to be conscious about how do this work in the clinical setting, in the primary care setting. And this is something that we still don't know how to do, but I think we are in the right way of doing that.
Thank you very much, Sylvia. I think one further question we'd like to ask is, in a region with high social inequity and fragmented healthcare systems, how can we increase the rate at which individuals with NAFLD are detected and diagnosed? And this is perhaps a question for anyone on the panel who wants to jump in.
Sorry, can you repeat the question, Rob?
Yes, sorry. In a region that's characterized by high social inequity and fragmented healthcare systems, how can we work to increase the rate at which patients with or individuals with NAFLD are detected and diagnosed so they can be appropriately managed?
Yeah, that's a great question, because if we are thinking about like diagnosing and referring 25% of the population or even 30%, that's not realistic, right? So we need to focus on what we want to identify and how. There is some agreement between the liver community that we should identify those patients that are already progressing, so basically advanced fibrosis. So then how we are going to identify those patients, there are some inexpensive ways to do it. For example, the use of FIB4, which basically use liver enzyme, AST, ALT, H, and platelets to develop a score, and that can allow us to identify patients who are at low risk of advanced fibrosis, high risk of advanced fibrosis, or then an intermediate stage. There is other ones, for example, NAFLD fibrosis score. Currently, like FIB4 is the most used one. If we can implement, for example, FIB4 in the electronic medical records and shows results every time someone requests liver function test. So, for example, a family doctor can have the results there with an interpretation so they know when to refer the patient. Those are the kind of things that can help in an inexpensive way to identify those patients that are at higher risk of having more advanced liver disease, and those patients will be referred. How much will be those? So will be, I don't know, 2%, but it's not 25 or 30%. So that's one of the way that we can do it in a low resource setting. With more resources, we can think about elastography, such as FibroScan other kind of elastography or even MR elastography. But I think for Latin America, the way to do it is with a non-commercial cheap scores.
If I may add something, Rob, what Pablo, I agree 100% with Juan Pablo, but I would also bring into our attention and the primary care setting is combine the FIB-4 and also the HOMA index, because FIB-4, for instance, relies too much in body mass index. But we all know that insulin resistance is one of the main drivers of fibrosis. So if you have a patient with a liver chemistry above the normal values, but also those patients have insulin resistance, definitely you need to check for fibrosis or for advanced disease. That is cheap and also available in any clinical setting.
Yes, I fully agree with Juan Pablo and Silvia. However, you know, I think in the general population, yes, we can use, you know, the non-invasive biomarkers. But in other cases, when we have patients with insulin resistance and also another abnormalities, metabolic abnormalities, we need to use another tools. The elastography probably is the good one. In Latin America, I'm sure that in many countries we have this kind of tool, and also, you know, there are another algorithms like ADAPT I mentioned before in my talk that is a little bit easy to do it because it includes also the measure of the collagen 3 in our patient. That is a very good marker for to detect the liver fibrosis stage.
Well, yeah, I'm afraid I'll have to close this, unfortunately. Thank you. And thank you all. We are on top of our time. And yeah, it's been a wonderful and rich discussion. Thank you so much. We're very grateful for our speakers and for the grateful presentations, for accepting our invitation to be here and to share your expertise and contribute to our discussion. Thank you so much for all of you who attended this session. If you had a question that we didn't get a chance to get through, we'll make sure to send offline the responses to you so we can save the chat and send all responses back to those who didn't get a chance to hear it here today. You will receive a recording of this session so you can watch it again or you can share. And yes, anyone else wants to share anything before I close this for good? Also, thank you all and see you next time. Bye.
Thank you for the invitation. Bye.